So this is on what is sometimes called Medicare for All. I hate that term. We used to say expanded and improved Medicare for All, but apparently that was too long. Um, the economic term of single payer isn't very self-explanatory, and in most places of the world, we just call it national health insurance, or in the case of the New York Health Act, state health insurance. Um, and while I often give these talks in the sense of a general, this would be better for our patients and the communities we serve, this particular talk is going to have a little bit of an emphasis because I understand you guys, many of you have had some basics around single payer before. I'm going to have a little bit of an emphasis on why it would actually be good or even better than the current system for doctors and hospitals, since there's a lot of myths, some of it from corporate lobbyists, about how this would be harmful somehow. So there'll be sort of the self-interest, quote unquote, guild reasons coming in here. You will see everybody should have the slide set, and everybody, you'll notice that there are academic links on almost every slide. Um, so this does cover ACGME requirements under the sort of administrative category. As I said, I'm consider myself a patriot, and one term for this might be the All America Health Plan. As we go with our red, white, and blue here. Um, so my disclosures are, I, am on the board of directors of Physicians for National Health Program. I don't receive any compensation, have any financial interest. In fact, it costs me money. Clearly, I've, gone to Albany and done Albany lobby days and stuff like that. So why do doctors and hospitals, why might you, quote unquote, not yet support single payer? I gave this talk recently at a national hospital conference, the Becker's National Conference in Chicago, and we actually had some pro single payer executives on the panel, and they suggested that for doctors and hospital executives, fear of the unknown, fear of change, fear of loss of personal income or institutional revenue, and something of a faith, inherent faith we have in the United States in the private sector being somehow inherently better than the public sector, or corporate Wall Street, hedge funds, and private equity somehow better than elected government. I would suggest that rather than fear and faith, we can look at some facts and evidence. So let's go back to very first principles. What is the purpose of insurance? What is the whole point of having an insurance pool? And the whole point, the theoretical economic point of an insurance pool, is to spread the risk. This is for any event that is too expensive at the point of the event for one individual to be able to pay for it, but where that thing is needed. And this applies to whether it's ships going out across the ocean being insured by Lloyd's of London, um, or home insurance, fire insurance, auto insurance, malpractice insurance, or health insurance. The whole point is what's called risk pooling, that everybody is paying in, and everybody is paying in all the time continuously. So we can think of that as our taxes paying for the fire department. We can think of that as our premiums paying for our health insurance. But I would suggest that, given that the whole point is risk pooling, that the most natural and efficient pool is everybody in the United States. And hence the seeming political slogan of everybody in, nobody out is actually an economic slogan. Contrast this by what is the actual business of corporate for-profit health insurance. Well, their business, their fiduciary legal responsibility is to make a profit. And in fact, what they use the pool of money for is as an investment pool for Wall Street. And actually providing health care is what in supermarket terms would be called their loss leader, to get you in to buy, in other words, to pay the premium. And they actually refer to it as medical loss ratio, hence the word loss in there. So what we call healthcare, they call a loss. The way that they, these fragmented multi-payer system compete is they cherry pick. In other words, they compete by selecting that subset of the pool which is less sick and more has more money. In other words, the healthy and the wealthy. And they lemon drop by dumping anybody who gets sick back into the public pool. And so we see with things like Medicare Advantage, the healthy come in, and then when they get sick, they find ways to dump those folks back into fee-for-service Medicare. So this is what we might call advantageous selection. This makes the public pools, Medicare, Medicaid, and the fact that a lot of the private is subsidized, pools more expensive. In other words, adverse selection. The other factor to bear in mind is that healthcare economics just doesn't follow a simple supply and demand model. We've known this since Ken Arrow, Nobel Prize winning economist, wrote some papers in the mid-60s on this. But basically, to have simple supply and demand, your buyer has to have complete knowledge and a complete ability to negotiate. And your seller has to be completely transparent and have flexibility in pricing. None of those things apply. The general public, both before they get sick when they're paying premiums and when they get sick and encountering narrow networks, copays, and deductibles, don't have full information around healthcare, have no ability to negotiate or do some competitive shopping. There's a complex three-way dance, if you will, between the doctors and hospitals driving demand and payers slowing demand, and frankly, with patients caught in the middle. So how do the other rich capitalist democracies do it? In a word, they do it better. This is a composite of performance on a whole series of factors, looking at healthcare system performance amongst peer countries. This is 10 countries plus the United States, and what we see is there's a cluster of other countries, all of whom do it differently. Canada, France, Germany, UK, Switzerland, Netherlands, New Zealand, Germany, Norway, all do it a bit differently from each other, but they do have universal guaranteed coverage for everybody in the country, with very limited amounts of out-of-pocket expenses. And we can see the U.S. is 11th out of 11th, both the worst performing system and the most expensive system. So the U.S. pays the most. This is GDP per capita. And what you can see here is that not only is the United States paying the most, the one in orange, but it's diverging. It's the differential is accelerating compared to the other countries. And we have the lowest life expectancy. So we're paying the most, we have the worst life expectancy, and that life expectancy is getting worse. And it's getting worse relative to these other countries. So you see, back in 1960, we were kind of middle of the pack. If you look at the red, where the red is compared to the gray on the far left. And over the years, as other countries have gotten a lot better in their life expectancy, the United States is increasingly diverging away from those others. And we have gone from middle of the pack to over 3 years behind the worst of the other countries. I would suggest that what this is saying is, we often say, well, our life expectancy isn't as good because we have a worse situation historically with enslavement and racism and immigration and diversity of communities and so on and so forth. Well, we had all of that previously, and those factors don't account for the divergence. Something else is going on. We basically have, if you combine those two prior slides, the worst bang for the buck, if you will. If you look at life expectancy versus health expenditure per capita, there's the rich capitalist democracies with universal health care in gray, and then there's the USA in red. And to quote Sesame Street, one of these countries is not like the others. And again, the fact that it's getting worse and worse over time since the 60s and 70s is suggesting that it's not just our baseline differences in our racist disparities and immigrant and diversity. This is showing that we are doing worse in a more direct healthcare system outcome. This is looking at avoidable deaths, a subset of mortality, and the 10-year reduction in avoidable mortality across different countries. And what you see here with the United States and the right is, first of all, we are the worst in terms of the avoidable deaths per 100,000, and we have had the least amount of improvement over the 10-year period between 2009 and 2019. So again, one of these countries is really not doing as well as the others. Other countries are not rationing. You often hear the claim, hey, it's all about rationing. Well, this is looking at the hospital inpatients per day, days per capita. And what you see here is on the basis of how much care is being given, to the extent that hospital inpatient days per capita is a measure of how much care is being given. It's the United States that is providing the least amount of care, that has the most rationing, if you will, compared to our other peer countries. Other countries are not rationing on the outpatient side. If you look on the chart on the left-hand side here, this is the average outpatient visits per capita, and the United States is again towards the bottom. OECD average of 6.8, and the United States at 4.0. By the way, we also have less practicing physicians per population. Um, 2.6. Now, some of the other countries, notably Canada, which I know quite well because of having family members there, has had some recent issues with that. But those, again, are recent policy issues where conservative governments in some provinces have reduced or frozen the number of medical school seats. But overall, compared to the entire rest of peer OECD countries, we have less inpatient care, less outpatient care, and less doctors per population. Um, it's the US that's rationing by ability to pay as opposed to healthcare need. So this was, again, an international study done to asking people systematically the same way, and it's been done for several years across multiple countries the same way, with the OECD and the Commonwealth Foundation collaborating. To look at the percentage of persons who reported any cost-related access problems due to medical care in the past. And what we see here is the respondents in the United States, first of all, overall is higher than in any other country. In fact, it's so bad that the higher income, I believe these were quintiles, the highest income quintile in the United States does worse than the low income quintiles in all the other countries. So poor people in the other countries report less skipping of care than well off people in the United States. And again, I would suggest this is indicating that the United States system is pretty badly broken for our patients and the communities. There's been numerous studies looking at excess deaths due to uninsured and underinsured. Advocates from PNHP often cite the 68,000 excess deaths per year and a 28% higher mortality compared to peer countries and compared to what it would be, rather, in the United States if everybody had comprehensive insurance without copays and deductibles and point of service payments skin in the game. What's interesting from my perspective is if you look at the low number study, which was explicitly done to debunk. So the authors fully acknowledged that they were on the conservative end of the spectrum, if you will, and that their goal was to debunk the high study, the 68,000. And so the official debunking study showed only 18,000 excess deaths per year. And to me, that was quite indicative of something, and 6% higher mortality. There was a Lancet Review article in 2020, which is being updated as we speak. There's a pre-press publication, Missing Americans, going back to 1933 through 2021 and COVID. The previous one is through 2020 in the Lancet. And what we see here is 500,000 excess deaths in the United States compared to other OECD countries. And this is pre-COVID 2018 data. So what about Medicare, and why would we want quote unquote Medicare for all? Well, this is looking at age group specific mortality rates. 17 peer countries, age group specific mortality rates. And what you see here is the United States ranks essentially 17th out of 17 countries in age group specific mortality rates until age 65. And what happens at age 65? Well, lo and behold, Medicare kicks in, Medicare as is, if you will, kicks in. And all of a sudden, the age group specific mortality rates in the United States, we start doing a heck of a lot better. And in fact, in the oldest age groups, we do quite well. And once Medicare kicks in, providing almost universal basic coverage, for persons living in the United States. Well, what about ages 0 to 65? Well, my dad used to tell me back in 1970, gee, we should just have Medicare starting at age 0. And he was right. So what about the remaining uninsured, underinsured, and the folks for whom it's just too darn expensive? So before the ACA, we had somewhere in the range of 55 million completely uninsured. The figure varies depending on how the survey's done. Uninsured an entire year, uninsured at a given point of time when the survey's done, uninsured at any point during the year. The surveys are done in different ways and come up with slightly different numbers. Bottom line is the ACA did successfully move about half of the remaining completely uninsured to being nominally insured. Most of that actually was the Medicaid expansion. Only some of that was adding the ability to buy for-profit corporate health insurance through your state exchanges, often with public subsidies to help pay for them. So who are the remaining uninsured? So this is U.S.-wide data. New York State may be a bit different, but there's something of a myth out there of, oh, it's just folks who are undocumented. That's often touted as a statement. It's simply not true. So nationwide, at least, the vast majority of folks who are remain uninsured are remaining uninsured either because the administrative burden of figuring out how to get on insurance, the churn of being on and off different eligibilities, or the remaining cost in terms of paying the premiums is just too much. And that's the overwhelming majority. Only 16% are in the category of undocumented, and only 9% of the remaining uninsured would be insured if they were in a state that, in fact, had accepted the Medicaid expansion. I would suggest that the biggest problem is not completely uninsured. I would suggest the biggest problem is underinsured and healthcare just being too expensive, even for persons who nominally have insurance, combined with the problems of limited networks and needing prior authorizations and all the other hoops that we as both providers and patients have to jump through. What this graph is showing is that both the cost of a premium, and that includes the out-of-pocket costs for employees, as well as the cost to the employers who are sharing in that burden, has been increasing at about twice the inflation rate and twice the workers' earnings rate. And not only are premiums going up at faster than inflation rate, but the deductible, the amount that a person has to pay out of pocket before the insurance even begins to kick in, has been going up even faster. And those high deductible insurance plans are a real problem and have been expanding. Underinsurance in the United States has continued to grow. Unfortunately, the ACA did not eliminate this problem. We can argue about what your definition of underinsurance is. Key thing here is Commonwealth Fund is using the same definition over multiple years, having to pay more than 10% of income on out-of-pocket costs. And that's gone up as a barrier to care for patients having to either go bankrupt or not actually, fill the prescriptions or what have you. Narrow networks. We've all encountered narrow networks. We all know that, your health insurance covers you at one hospital or in one set of doctors, but not at another hospital or another set of doctors, even if you have pretty good private insurance. We have pretty good private insurance in my family, and my wife has to, for some TMJ jaw problems, has to go. We live on the Upper West Side of Manhattan, and the only place that's in network is in Sunset Park, the former Lutheran Medical Center. So we're supposed to have all of NYU and all of Northwell, but individual practitioners don't take it. And she winds up going to South Brooklyn for that care. The most common narrow network in the United States is Medicaid. So you can be nominally insured if you have Medicaid, but 75% of physicians in the United States don't take Medicaid. Now, as a pediatrician, I'm proud to say that roughly 70% of general pediatricians do take Medicaid, but once you get into pediatric subspecialists, the vast majority don't take Medicaid. And what we see here in this graph is a high percentage of folks who take private insurance amongst the ped subs and don't take Medicaid. So again, limited network. You may have to travel long distances and have super long wait times in order to get care, even if you're nominally insured. Um, Underinsured, co-pays and deductibles going up. There's this myth that got propagated, unfortunately, ever more so with the ACA, that patients somehow need to have skin in the game, that the patient has to pay out of pocket at the point of service, otherwise there will be overuse. This is false for multiple reasons. Basically, doctors, jet, and hospital care is what actually generates demand for care. We're the ones saying so and so needs, you need a prescription, you need this procedure. The patients aren't self-generating that. And what this shows, and these are some recent studies, the references are at the bottom, is that transitioning to a higher deductible health plan in persons with non-specific chest pain did successfully result in persons who were symptomatic with chest pain, did successfully result in their having less ER visits, less hospitalizations, and less invasive hospital testing when they switched from low deductible to high deductible plans. And it successfully increased their 30-day acute mortality rate, acute MI rates, by 16%. Literally, skin in the game is killing. Another study that showed this was a switch over on Medicare patients, increasing their copay. Um, Basically, $10.40 increase in the copay for drugs successfully reduced total prescriptions filled. In other words, patients were quote unquote not complying with filling the prescriptions. This included a bunch of medications, and it successfully increased their mortality rate by 32, almost 33%. So congratulations, copay, skin in the game literally kills. There's numerous other studies, 3 through 6 here in this chart, including pediatrics, so even young cancer survivors, a group that absolutely obviously needs their medicine, and you cannot say, oh gosh, you overusers, you poor young cancer survivors. They absolutely need their medicines and follow up, and those with less copays had lower non-adherence. Um, Fact is that healthcare spending is driven, first of all, by doctors and hospitals saying you need this care, and it's driven by very sick people who really need care. We know for a fact that in fact top 1% of persons with the highest healthcare spending account for 20%, and in fact the top 20% account, the 20% of people account for 80% of U.S. healthcare spending. My apologies. The reference for this must be underneath the slide. I will provide it subsequently if you remind me. Healthcare costs are the leading cause of personal bankruptcy. So 2/3 of those filing for bankruptcy attribute healthcare costs as the major factor. So just to go back for a moment, the point of this is that you putting point of service charges, copays, deductibles, out-of-pocket spending at the point of service for the patients doesn't save money, but it does reduce necessary care and kills people. That's why single payer bills usually have no or minimal copays point of service. And economically, it makes sense not to. 2/3 of those filing for bankruptcy attribute healthcare costs a major factor for their personal bankruptcy, and 3/4 of those had health insurance when they became ill. So again, it's not the uninsurance that's even the biggest problem. It's the underinsurance. You have health insurance nominally, you get sick, and you go bankrupt anyway, either because of all of the costs that your insurance isn't covering, or the fact that you have employer-based health insurance, you get sick, you lose your job, you're uninsured. 57% of folks who lost their homes during the mortgage crisis actually cited medical debt as the major cause for why they couldn't pay their mortgages. Medical bills, the most common reason for collection calls, etc., etc., etc. So what we like to say is that underinsurance is the biggest problem, and that having private health insurance is kind of like having a hospital gown. The chances are you aren't covered. Let's put it that way. Again, the copays, the deductibles, the out-of-network, the unreimbursed out-of-pocket costs, that whole trade-off of higher versus lower premiums versus more or less out-of-pocket when you do get costs, limited networks, et cetera, to say nothing, of course, of the prior authorizations. So what is single payer? Very quickly, single payer, publicly funded privately delivered insurance. The change is in the financing, not the delivery. So the proposals all say the current system, that's currently a mixed system, as you at Downstate know, of having independent private doctors and private hospitals and public doctors and public hospitals. And some doctors are on their own entrepreneurs and some are employees. All of that stays the same. What's changing is instead of a fragmented multi-payer, uh, on and off, different eligibilities, churn, it's just automatically there for everybody, paid for by progressive funding. So replacing the flat tax of premium copay and deductible, where rich people and poor people pay the same premium, with a progressive tax. And very importantly, it's not just currently Medicare as is, expanded to age 0, but a massively expanded and improved benefits package, all medical, mental, and dental, hearing, vision, drugs, and very importantly now, for the last 8 years or so nationally and 6 years in the New York Health Act, comprehensive coverage for long-term care, outpatient, home care where still possible, and residential nursing home care where needed. No pointed service costs. I would suggest, using patriotic terminology, that it is increased freedom of choice for patients. You always just have it. All the doctors and hospitals and healthcare providers take it, and so, if you will, it's capitalism at its best, where all of the providers are now competing to take you as a patient, on an equal basis, and it has maximum security because you always just have it regardless of employment or other changes in your life circumstances. We'll see the economic arguments, but as well in terms of the cost savings to the system and the fact that it actually boosts the economy overall. Total system-wide savings, less expensive for anybody who's a current contributor to the healthcare system, including any employers that are helping to provide premium coverage for their current employees. Um, and also actually a net economic boost and net jobs. Basically, though, there's also the moral argument. Is access to healthcare a private for-profit commodity to be purchased like your widget du jour, or is it a social need or a communal good like like the fire department? You know, the fire department doesn't ask you. It's prepaid in your taxes. If you have a fire, they come and they put it out. They don't ask you if you're in network, just the closest fire department comes. They don't demand out-of-pocket costs before they start to put out the fire, et cetera, et cetera. Bottom line is, it makes economic sense. Over 30 studies, including the conservative groups like the RAND Corporation, the Congressional Budget Office, et cetera, have all agreed when they've done multiple analyses over many, many years. Total reduction in total system-wide spending. So it's not costing too much, it's actually costing less. Net increase in worker earnings, worker longevity and productivity, and a net boost in economy-wide productivity. RAND Corporation, center-right organization, suggested a productivity boost of 180,000 additional jobs with the New York Health Act in the United States. So where do those savings come from? How does expanding care and reducing out-of-pocket costs save money? Well, it saves money in the following ways. First of all, there's an insurance overhead. There's the cost of running the insurance scheme, if you will. And in the United States, because of it being for profit, because of it being multiple payers, multiple groups, and because of the churn of on and off different eligibilities, it costs roughly 5 times as much in the United States as it does in most of the rest of the world, on the insurance overhead side. We can see that Medicare as is leaner and more efficient than commercial health insurance. This is the cumulative growth in per enrollee spending. And certainly Medicare, since it's covering the elderly and the chronically ill, is already inherently going to be covering the sicker people who are getting sicker and needing more and more care and needing more and more expensive care than commercial insurance. And it still has controlled costs better than commercial health insurance. Medicare's overhead in the United States of about 2% compared to an ostensible cap with the ACA of around 15%. Medical loss ratio, administrative and for-profit overhead in the health insurance companies. Um, So that's all on the insurance side. What about on the provider side? Well, if you look at the physician billing related expenses, again, the United States is about 5 times that of other countries, in this case, Canada. And if you look at the hospital billing and administrative, it's about 5 times others. So that's all of those people that are pushing the paperwork, either in a doctor's office or at the hospital, to the insurance companies to get paid. Um, and arguing at them and resubmitting when it's automatically denied the first time, and going through jumping through all of those hoops. What we see here is a comparison between Duke Medical Center and an article from JAMA. Duke Medical Center, Academic Medical Center, obviously 957 beds across 3 hospitals, 957 beds, and for which they have 1,600 billing clerks. Think about that for a moment. More than 1.5 billing clerks per bed. Toronto University Health Center, Academic Medical Center, University Hospital of Toronto, and its affiliated nearby hospitals, a total of 1,272 beds in 5 hospitals, confirmed from their senior staff person. They have 7 billing clerks for 1,272 beds. This slide used to show 1 hospital, the main University Medical Center, and 3 billing clerks. We added the additional ones per some additional conversations with them just to make it comparable. But essentially, at the big university hospital, they have 1 billing clerk for Ontario, 1 billing clerk for all the other provinces, and 1 billing clerk for the rest of the world. So what about the growth in healthcare administration compared to physicians? Again, the growth in physicians from 1970 to 2021 over 50 years is less than double the number of physicians, less than 200% growth. The growth in healthcare managers and administrators is 4,000% by comparison. So what we see here is an ever-growing number of physicians managing a not very growing number of physicians. And anybody who's practiced for a long time has seen all of that growth of the administrators over you going up, up, up. This is not efficiency. This is not healthcare. The doctors provide the healthcare. The other health practitioners provide the healthcare. The managers do not provide the healthcare. So all of that adds up to a fair amount of savings. This is a nice way to look at where those savings and increased costs come from. This is the Rand Corporation, certainly not an advocacy group, center right, if anything, analysis of the New York Health Act here in New York, single payer for New York State. It's just a really nice graphic showing the reduced insurance administration costs, 6.5%, to reduce hospital and other provider, physician administrative costs. And then, of course, there's the reduced prices on the drugs and devices, because we're negotiating the prices from the stance of a strong, large buyer having a greater ability to negotiate the prices, what's referred to as monospony as opposed to monopoly, where the buyer has power. Yes, there's additional costs from covering everyone and eliminating the cost sharing. Yes, there's actually improved provider fees, as we shall see, and adding in long-term care. So there's a net savings, a net increased costs, and the net savings of 3.6%. The other thing that's really important to emphasize in single payer plans is that roughly 92 to 98%, depending on the details, on average 95% of persons pay less. So only the highest income folks would be paying more. Progressive taxation replacing flat tax of premiums, copays, and deductibles. So the big lie is that it's too expensive, and the big truth is that it's actually cost savings and cost shifting. So reduction in total systems costs, reduction in costs from over 90% of families and households. By the way, about a $9,000 savings per employee for employers that are currently co-paying on their premiums. And by the way, when you're saying employer savings, that means the hospital's an employer and government as an employer. So in fact, lower levels of government, so counties and cities in the case of the New York Health Act, and the states as well in the case of national single payer, government saves money because they save money for their employees, the police, the teachers, etc., as well as having lower state Medicaid cost shares and having full reimbursement for all of their public hospitals where they've been having low reimbursement for uninsured coverage. So why is single payer good for doctors? Let's first of all look at what's happened in the U.S. healthcare system. For those of you who even get this reference, Marcus Welby is dead. So this is showing how much of private equity takeover in healthcare, over $750 billion over the past 10 years. The authors of the report refer to this as consolidation accelerating, competition is being undermined, and patients are at risk. I have a whole bunch of slides that I'm not including here on the fact that for-profit healthcare, whether it's the for-profit hospitals, for-profit nursing homes, for-profit hospice care, etc., all of which provide worse outcomes than not-for-profit. So the increasing amount of for-profit, whether it's the old-fashioned Wall Street companies, the new private equity and venture capital and takeover of healthcare, is causing harm to physician autonomy and harm to our patients. Even nominally nonprofit healthcare systems are becoming speculative investors. So here we see Kaiser and Mayo and Mass General Brigham and Cleveland Clinic, all of which are now doing hedge fund investments and private equity investments with all of their excess accumulated capital that they're not giving to either physician income or reducing costs for their patients. We have gone, this is just 3 years from 2019 to 2022, January 2019 to January 2022. So essentially the year of 2018 to the year of 2021, showing rapid increase in the percentage of employees, physicians who are employees. So again, Marcus Welby is dead. The self-employed, self-practicing physician, solo entrepreneur, even group practice entrepreneur, making their income on the basis of fee-for-service billing, that's dead and gone. Overwhelming majority of physicians are now employees, either of hospitals or of other corporate entities, and it is growing fast. Physician job satisfaction in the United States is lower than it is in the other developed countries. This is just looking at primary care physicians who are extremely, very, or moderately satisfied with practice of medicine. This is physicians rating their healthcare system. And again, the U.S. physicians rate their own healthcare system as the poorest compared to the other industrialized capitalist democracies. U.S. physicians spend less time with our patients. Patient care, only 26%, compared to 65% in Canada of our time is spent in direct patient care. And we know how much is taken over now by electronic health records. Quite the misnomers we'll see. It turns out that when it comes to electronic health records, what we see here, for example, is Epic, the software product Epic, is used not only in the United States, but it's also used in other countries. So this is a study that was looking at the average number of keystroke characters, how many keystrokes you have to do to complete an Epic note for ambulatory care practices in the United States. And you see a nice distribution curve here for for the institutions in the United States. It's 254 organizations and 10 million notes in the United States compared to 13 organizations in a bunch of other countries. So let's take a look at the distribution curve for the number of keystrokes per ambulatory care note using Epic, ostensibly the same product, in those other countries. There is zero overlap. The fact is, it's not an EHR, it's a billing record, it's an administrative record, and you can take Epic and simplify the number of keystrokes and amount of time being spent if you get rid of that. So 3/4 of our charging is for billing and insurance, not for clinical work. Annual cost to a physician practice interacting with insurers, US compared to Ontario, again, about 5 times. What about incomes? Well, guess what? Doctors in other countries make really good incomes, and the subspecialists make more than the primary care practitioners. Um, and they do just fine, thank you very much. So family medicine in Canada and ophthalmology in Canada is shown there, for example. And in fact, median ophthalmology makes more in Canada in some of those subspecialists than they do in the United States. Um, Medical practice overhead, again, far less. Whatever you're earning, you get to keep more if you're in Canada, obviously. So the claim is often being made about, it's going to hurt physician income. Well, these are three estimates by three different groups, going from the very far right, extremist right, Mercatus Institute, funded by the Koch brothers, the Rand Corporation, a center-right organization, if anything, and the Urban Institute, which, although nominally progressive, at least when it comes to healthcare, is completely associated, frankly, with the Clintons, and have been opposed to single payer, although they're certainly progressive in many other ways. But even Mercatus and Rand are saying that, gosh, there will be at least as much, if not more, under Medicare for all. In fact, there'll be more for Medicare for all. Three of them are showing in the yellow than under the current system in terms of total payments to physicians with and without Medicare for all. So current system in the green is less than Medicare for all estimates under all three analyses. Single payer would have more payments to physicians than the current system. In fact, physicians, there used to be the old trope of, oh, all those Canadian physicians are fleeing. In fact, the Canadian Medical Association strongly supports the current system. They wish there was more investment in it and less cutbacks by some governments, some provincial governments. But in fact, it's American physicians that are moving to Canada for a whole bunch of reasons, but one of which is that practicing medical care in Canada is, frankly, more enjoyable. I've got relatives there. And in fact, Canadian physicians are going back home. There's been a net migration back of Canadians back to Canada, of Canadian physicians. And again, the bottom line is it's not a big hassle, can focus on patient issues, as opposed to here in the United States, where everything is a bureaucratic mess and patient care is item number 3 out of 4. Increasing support for single payer amongst physicians. This is a survey done by Merritt Hawkins, showing in 2008, 42%, climbing to 56% in 2017. Not the greatest methodology. So Merritt Hawkins is a for-profit headhunting firm, job placement firm. They use the same methodology across both time frames. When I actually looked at it, I was not terribly impressed by the methodology, but it is the same methodology across both time frames at least. Far better methodology, of course, was Ackerman and Carroll, publishing in the Annals of Internal Medicine. Really good, tight methodology, showing support going from 49% to 59% over a 5-year period. The 2002 to 2007 is the data points, not the publication dates, but the actual survey dates that the survey occurred in. And again, the references are there below. Obviously, there are differences amongst the different specialties in terms of how much support there is for single payer. And obviously, there is also regional differences as we would expect. Nevertheless, organized medicine, which historically was opposed to this, going back to the 1920s Red Scare. By the way, before the 1920s Red Scare, back when Teddy Roosevelt was running on the Bull Moose Party with national health insurance, the AMA at that time supported it. Interestingly enough, but from the 20s to the present, the AMA has actively opposed Medicare for all. However, we got what I would call a moral victory when in 2019 it was proposed to the AMA House of Delegates to stop opposing Medicare for all, and that vote lost by 40. We got 47%. We lost 53 to 47%. Your academy, ACP, for internal medicine, as of January 20, proposed only 2 ways forward as a new policy position: either Medicare for all or a really strong version of public option. And Society for General Internal Medicine, I believe, is actually endorsed single payer solely. Here in New York State, My academy at the state level, the New York State Pediatrics and New York State Family Practice have both endorsed the New York State Health Act for single payer. So bottom line is, what would it do for physicians? It would preserve earning potential. It would increase physician autonomy. Um, it would increase career satisfaction, decrease administrative burdens, eliminate the requirements for prior authorization of treatment, eliminating the need to limit your fees to join narrow private networks. And again, every doctor just takes it. Every patient who shows up just has it. Um, Imagine how simple life could be. Better for hospitals. So big argument during the last round of Democratic Party primaries in the lead up to the last presidential election. And some of the hospital associations joined in with the insurance companies to fund ads saying, oh, well, if you do that Medicare for all stuff that Warren and Sanders are supporting, all the hospitals in the United States would close and it would be terrible, terrible, terrible. Um, so ignoring for a fact that, of course, every other industrialized capitalist country does it. So somehow they're saying only the United States would somehow be unable to do it. And that, of course, we advocates somehow don't want what's better for the population. Let's look at some reality. So in the United States, it's the current system that has less hospital beds than other countries. So again, OECD comparable countries average of 4.6. United States 2.9 hospital beds per person. So somehow they're keeping their hospital beds open despite having universal coverage. U.S. hospitals, however, are staffed quite differently than hospitals in comparable countries. The teal shows the number of healthcare providers um, per thousand people employed at the hospitals. The United States is at the bottom of that, 11.2 compared to the others. We do, however, apply, as you would expect, more administrators. So again, hospital employees per thousand population, United States, less healthcare workers, but more administrators. Um, it's the current system that's failing us all. Hospitals today in the United States under the current system are having to downsize and close. The left side box shows the total number of closures in the United States in each of those years in terms of how many hospitals outright closed. That's not even including downsizing, reduction in services, etc. You may have seen in the press, we don't feel it as much living here in New York City, but there is a huge rural hospital closure. 101 hospitals have closed since 2013. 180 since 2005. This has increased the average travel distance for persons living in rural America from 3.4 miles to 24 miles. And as you can imagine, you increase the travel distance, your outcomes get worse. Let's just put it that way. If you have a heart attack, travel distance makes a difference. Here in New York City, those of us that remember the Berger Commission's plural 2 rounds of hospital closures in New York City, mostly since 2000, over 19 hospitals have closed just in New York City. New York State has gone from 3.3 beds per thousand population to 2.7 beds per population. And what we saw, especially hitting us during COVID, is the disparity that that in Queens, there's 1.5 beds per thousand population compared to Manhattan, 6.4 beds per thousand population. Growing up, we used to refer to the Midtown East Side of Manhattan as Bedpan Alley. Now, we could certainly say that, well, with modern healthcare, we've got shorter lengths of stay, legitimately, and we're doing more procedures on an outpatient basis, and so we could reduce the total number of beds. And I agree. That statement is true. We could reduce the total number of beds, but it's not being done fairly or evenly, and it's not being done on the basis of need. The reality is that those reductions in services and downsizing and closures are mostly in poor rural and poor urban areas. And rich urban and rich suburban areas get more. The strongest predictor for hospital closure is serving a higher percentage of people of color, and studies show increased travel time associated with worsening outcomes. There are studies from Philadelphia on urban, and there's studies on rural as well, references below. Hospital closures are not occurring in overserved areas. They're occurring disproportionately in poor neighborhoods and already medically underserved areas. This is just showing mapping the hospital closures in New York City by poverty and by underserved areas over different periods, going all the way back to 1963. You want to talk about structural racism? This was a brilliant study that I would suggest shows literally structural racism. This is the value of new capital purchases and total assets in U.S. acute care hospitals, literally the brick and mortar, as well as the equipment and supplies, for hospitals serving mainly white folks in red, mostly Latinx folks in yellow, and black serving predominantly in teal. And what we see here is higher purchases and higher total assets in hospitals serving white folks compared to brown and black folks. Similarly, black serving hospitals get paid more, reimbursement per inpatient day, and profit per inpatient day for black serving versus other hospitals. So let's debunk the myth. So the argument that the companies were making is private insurance pays more than Medicare pays today. Therefore, an all Medicare payment system means less hospital revenues. Therefore, less revenues, exacerbation of hospital closures, particularly in critical areas. That's what the hospital lobbyists were claiming. So let's see if any of that is true. In fact, they're all based on false assumptions. So, payer mix. Private insurance pays hospitals more than Medicare pays today. Well, it's a false assumption, starting with payer mix today is not just private versus Medicare. Actual payer mix includes Medicaid and uninsured and underinsured and charity care. And it's those hospitals that are taking care of the full range of payer mix that are the ones that are financially stressed. Single payer would help those hospitals that are taking their fair share of all patients. What about the rates? That an all Medicare payment model means less hospital revenue. Well, first of all, one assumption there is that Medicare today has some mystical one set of rates, and that would be applied the same everywhere. In fact, the rates already today vary by whether you're a teaching hospital or rural, and the other things that give you legitimately increased costs, and that would continue. In fact, single payer models are not based on current Medicare rates. They are based on ongoing negotiation. The only detailed analysis that was done, which was by the Warren campaign, suggested about 110% of current Medicare rates. So that would be the Medicare fee-for-service rate would be about 10% higher than currently, as sort of what that model would be. And frankly, the hospitals are currently profiting net on Medicare fee-for-service by 8%. So in fact, they are not losing on just Medicare nationwide. The hospital profit on Medicare fee-for-service was a positive 8%, according to the MedPAC report to Congress. And so the statement is just false. They are not losing money on current Medicare. Maryland hospitals thrive under an all-payer model where everybody has to pay on the inpatient side the same rate based on current Medicare. And frankly, to the extent that single payer would expand global budgeting instead of fee-for-service, then the entire issue is mooted. Fact is, you would have transparent, accountable process funded to protect hospitals equally across all populations based on need. The other thing that the lobbyists forgot to mention is that hospitals save money under single payer. So reduces the operational overhead, the billing, the administrative costs that we've seen. The hospitals would have lower costs on their drugs and supplies and equipment, since those prices are now being negotiated, as they are in every other developed country and as they are not in the United States. And the hospitals, as an employer, would be paying less for their employees' health coverage. And so there's savings that way. And the savings there, again, are estimated anywhere from a low of 10% to a high of 20%. So again, the same three groups: Mercatus far right, Rand center right, and Urban Institute center left. Current system compared to Medicare for all, single payer would be paying more to hospitals than the current system. Even conservative groups agree. So it's the current system that is financially stressing hospitals with perverse system of financing, where financing is not related to patient need or necessity or community need. It's based on for profitable procedures, seeking preferential case mix, and gaming in your billing to optimize your billing. Incentivize, obviously, counterpoint to reduce less profitable services and avoid less profitable patients. Hospitals, not based on community need. It's the ones with higher need that are in fact closing, capital investments going to the areas that are already well served. None of this makes sense. And frankly, the COVID pandemic showed, worsened and highlighted what I would call the pre-existing condition of our sick financing system. So you had a situation under COVID at the beginning where your inpatient and intensive care was more busy, more overfilled than ever, and yet billing revenues went down because the better paying procedures were all put on hold. That's crazy, right? I mean, here we have more sick patients than ever, filling up the hospitals with a higher, way over capacity, and their revenues are going down at the same time. That suggests you're not financing your system properly. Corporate insurance has increased their power over the hospitals. The hospitals are complaining more and more about not being able to provide care, interfering in medical decisions with prior authorization, and interfering with the hospital's revenue through the insurance company's premeditated policy of deny, delay, and reduce payments. Deny payments, delay payments, and then reduce payments compared to what was promised. So for the hospitals, there's been lost revenue and delayed cash flow under the current system, and it's getting worse, worse, worse. Global budgeting for hospitals just makes sense, and it's what other countries do, and it's actually being done here in the United States on a limited basis in Maryland, Massachusetts, and Pennsylvania. The whole point is, let's uncouple the budgets from individual case service reimbursement. Why should a hospital budget be tied to how much you're billing individual patients for individual procedures? That makes no sense. You need the hospital in the community to serve the community. It's perverse that procedure reimbursement rates drive what services are provided where and when. Allows resources to be aligned with the needs of the hospital and the population, improves your planning and management. I know I'm running out of time here. Ends the hunt for most profitable interventions, allows you to focus on patient care and need. And as I said, it exists both here in the United States in various limited models, as well as in all the other capitalist democracies. So again, single payer, better for hospitals and patients. Hospitals, everybody has good coverage. Nobody's uninsured. You don't have to screen for eligibility. There's no on and off different eligibilities. Hospitals are not chasing patients for payment, bad debt, or charity care. The language in the New York Health Act specifically talks about having that the payments are reasonably related to the cost of efficiently providing healthcare services, and that their payments are high enough to maintain services. You don't get rid of the prior authorizations and deny, delay, and reducing their hospital's own expenses. And again, there's some additional studies that show that yes, the system could absorb the increased coverage once we, the United States, are not the ones that are actually limiting care and rationing care by ability to pay. Studies have shown that when other countries went to universal coverage, the system was able to absorb it, and there's studies showing that the U.S., similarly, before and after Medicare and Medicaid went in, and before and after the ACA went in, also were able to absorb the increased care. What's amazing to me is that the Hospital Association here in New York, which is opposed to the New York Health Act, actually makes our argument for us in their own ads against the insurance companies. So they were running ads targeting the New York State Legislature that the insurance companies' practice of prior authorization followed by denying payments, delaying payments, and reducing payments was terrible, and that they needed to protect hospitals and not the insurance companies, and we agree. Basically, the hospitals were saying we should have Medicare fee-for-service rather than managed Medicare, Medicare Advantage, or ACO REACH now. And we agree. I mean, it's been the case that fee-for-service Medicare has been doctors and hospitals' favorite payer for years, according to AMA surveys. So what about the alternatives? And I know we're butting up against 9:30, and my apologies. Quickly, legitimate arguments against single payer. The most legitimate one is it'll never happen. Is sort of the political argument that even though it's actually good for most businesses, our political system is so corrupt, our ideology is so rigid, that it won't happen. And the other one is that our system is too corrupt, and so even if it's passed, there would be regulatory capture by the worst players in it. I would argue, well, I'm going to just fight for what's best and move the ball forward as much as I can. Um, Republican alternatives basically amount to less expensive up front, but they don't work when you're sick. So health savings account essentially is an insurance pool of one, which works really well if you're a billionaire, or the so-called low-cost premium plans, premium plans, which are high deductible, high copay narrow networks, and may have caps. Um, the more conservative Democrats, in terms of expanding ACA and keeping for-profit and multi-payer in place, the problem is they don't actually solve any of the problems. So you get a few more people covered, but as I suggested, uninsurance isn't the only problem. Um, you expand Medicaid, but most providers don't take it because the reimbursements are low. You lower the age of Medicare as is from 65, let's say, to 55, but there's still huge gaps in Medicare as is and what it doesn't cover. And you don't get the savings because you're leaving in the multi-payer for-profit stuff. So you still have the churn and the administrative and on and off different eligibilities, still job dependence, too much out-of-pocket costs. So
Okay, all right.
again,
I
current
think we might have
system,
to. I think we
expensive,
might have to
add
leave
in
it
a
there.
public option, more expensive, and don't actually solve the problem. Single payer, less expensive, and solve the problems. I just want to take a moment and emphasize the progressive nature of single payer payments. So status quo, low income people are paying more. Status quo in teal and public option in orange. Lower income people, that's above the Medicaid threshold, but still low income, are paying 7, 8%, 9% of their income, as opposed to highest income people paying 2.5%. And under single payer, that's flipped. So public option shifts the curve, but doesn't change the shape. Single payer flips the curve to progressivity. So low income people are paying less of their income, and higher income people are paying a higher percentage of their income. Those who have more money are able to pay. I'd be remiss if I didn't at least throw in some charts for you to look at later in terms of how overall income inequality and wealth inequality is getting worse. How do you analyze any health proposal, single payer or otherwise? Is it universal, simple, and affordable? I've got some suggested criteria here for, is that healthcare proposal truly USA, universal, simple, and affordable? And I will stop here